I'd like to call to order the Western Lane Fire Defense Authority, Sister Valley Fire Rescue, Western Lane Ambulance District joint board meeting. Would you rise and join me in the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice. Mary, thank you, roll call.
Yes. SPFR and WLFEA directors, Director Heffel.
Yes.
Director Cleese.
Yes.
Director Carrillo.
Here.
Director Stanton. Director Mendolia. Western Lane Ambulance and WLFEA directors, Director Russell. Here. Director Webb.
Here.
Director Buss. Director Stent.
Here.
And Director Holbrook.
Here. And we have heard from Director Stanton and Director Buss that they would not be here tonight. We have quorums for all three entities, that's good. Any public comments?
No public comments.
Okay. So we're wrapping up the Western Lane Ambulance District budget, fiscal year 26 budget. So I think we've got everything going for that. So we're gonna open public hearing for the Western Lane Ambulance District fiscal year 25-26 budget. Are there any public comments for the budget?
No public comments.
Okay, hearing none, we'll close the public hearing at 6:05 p.m. And we have three resolutions for Western Lane Ambulance District. You can make one motion to pass all three resolutions if you'd like. If you do that.
I'll make a motion to pass resolutions 1, 2, and 4.
2, 3, and 4.
Should be 2, 3, or 4.
Oh, okay, 2, 3, and 4. I should bring my glasses. 125, 2, 3, and 4 for Western Lane Ambulance District. And the effect of approving the budget and approving the tax.
We have a motion. Second by Dr. Holbrook. Any discussion? Or to do roll call vote for Western Lane Ambulance District?
Yes. Director Russell. Yes. Director Webb.
Yes.
Director Stent.
We're looking for Director Stent. You want to
Yeah.
vote?
Yes.
Director Holbrook.
Yes. That was 4-0. Good. So it passes, and if you that wraps up our budget preparation. And now we have a special guest. I think we had a couple requests for system design to come talk to us about what they do for us, so we could do better. So we have Alyssa. Here, it's all yours.
Okay. I have a PowerPoint for you guys, so hold that up. Okay.
It's stand anywhere you would like.
Is there a preferred spot? You like US. So my name is Alyssa Christenberry. I'm from Systems Design West. We've done the EMS billing for Western Lane. I want to say since 2016. And I have been with Systems Design West since 2017. Western Lane was actually my very first client I ever worked doing claims follow-up, and I took you guys over with me to the billing department and coded claims for you guys for a couple of years. And I'm now an education director, so my job is to really go to our clients and provide them with educational opportunities, keep them informed of what's going on at legislative level, but also on the claims side, how to maximize reimbursement and all the fun stuff. So I wanted to give you guys a quick little overview of kind of how the billing side works and why your revenue goes the way it does. What causes those numbers to be what they are. So then also just a quick little sneak peek of us, because you always talk about us, so I'm talking to a couple of crew back there, and I'm familiar with their names from reading them on reports for several years, and Some of them are familiar from when I send emails back, and we don't really get a lot of face to face, but that's who we are. We do nothing but EMS billing and cost recovery for fire departments. We don't dabble in any other sort of medical billing. We're 100% US based. We've been in billing in Oregon, I want to say for over 20 years at this point. Our company has existed since 1989. So really the whole idea of this presentation is just to give you guys a good idea of what the EMS billing collections look like, why do we get the numbers we get, what do your reports mean? So we send you guys reports every single month. You can look at them and you have a good idea what they entail, but really understanding what those numbers mean and how they translate to your revenue. So this is, oh, it's a little hard to see. So this is the life cycle of a claim. So I think it's pretty important to paint the picture of how much goes into one single claim. So the moment the crews do a transport, we import it into our system. We review everything to ensure it's compliant for billing. We then send it to the billing department, which is that green section. They're going to review it, update patient information with their insurance, demographics. They're going to code the claim and either bill the insurance or bill the patient, depending on if there's insurance or not. And then it can have so many different end results after that. Whether we get insurance payment, we can post the payment and now settles it out. We could potentially get a denial from insurance, and then our AR department would do some cleanup on it. It could then go into a patient responsibility where they apply for financial aid. There's so many different outcomes. We can potentially get to a point where we have to do a refund or something along those lines. So we have all those boxes, and those are all different steps that could potentially impact even just one claim can realistically go through that entire process. And the little gray box is where that claim is complete. So one single transport to get the money for it goes through multiple different layers. And then we have our auditing department, which is our compliance department. And then we do our reports and other sorts of things to ensure everything looks good. So the biggest reason EMS revenue looks the way it does is Medicare and Medicaid. So we'll look at Medicare first. Medicare makes up 66% of your payer mix. So specifically for your department, last year you had a 66% Medicare payer mix, which is very, very high compared to those fire departments. Most fire departments are looking at 30 to maybe 45%. So being up that high is pretty remarkable. And then Medicare, so they have a fee schedule allowable, meaning no matter what, if a patient has Medicare, which 66% of your patients do, you have to abide by that fee schedule allowable. So, and I'm trying to think about the best way to describe it. So you guys are super rural. So that's another important piece of this. Medicare, not only do they have this fee schedule where they allow a certain dollar amount per level of service that you provide, but they also then give you a little bit more money if you're rural and a little bit more if you're super rural. And so you guys actually 99.15% of your claims fell into that super rural category. So the majority you're getting the maximum amount you possibly can for Medicare when it comes to what tier it falls into. So then we go down to the line items. So every transport you do, it doesn't matter if you've had just a dual paramedic transport, it's dependent on the interventions the paramedics are providing to determine what level of service we can bill to insurance. So specialty care transports, you guys do some of those on occasion. Those would only happen when you're going to hospital or skilled nursing facility. But ALS 2 is one step below, and then we work our way down. Medicare, it looks like, oh no, that's right, okay. Medicare though, so they say, we'll just look for example at the VLS. A VLS emergency in the super rural, they say we allow $558.14. Meaning we could send a claim to Medicare for $600, $6,000, $60,000, $6 million. They don't care. They say by law, you are only legally allowed to collect up to $558.14 for that base rate. So even if the patient's willing to pay more than that, if they have secondary insurance, it just goes out the window. If they have Medicare, it is the law you abide by their fee schedule allowable. So that's one piece of it. They also give you a mileage rate, and it's per mile that you guys transport. When it comes to the fee schedule allowable, that doesn't mean Medicare is going to pay that much money. What it actually means is they'll pay up to 80% of that, and then allow secondary insurance where the patient can pay 20% of it. So no matter what, like I said, it's not like we get that $558 from Medicare and then we just balance bill the patient or secondary insurance for the rest. We can only bill them for 20% of the allowable that matches that level of service. So I put an example at the bottom, and this was based off of a real transport by Western Lane. We had the base rate with a charge of $1,735, and there was 1.7 miles. So we were able to send a claim for $1,771.72. The allowable report is $581.71, meaning by law, we can't collect a penny over that. Medicare, if they paid that full 80%, it would have been the $465.36, leaving a remaining payable balance of $116.34. So that's where that disallowed amount now comes in. So you'll see some of the reports we send you guys on a monthly basis. There's a column always for what was the disallowed amount. That is what we are legally not allowed to collect. And so for that, there would be disallowed $1,190.02. So one of the biggest things that we encounter with our clients, they'll want to increase their rates because they're wanting to capture more revenue. What will happen often is that your disallowed amount is just going to go up pretty high with that. Oh, so then we have Medicaid. Medicaid is the other big hitter when it comes to any sort of medical billing. You guys have a 12% payer mix for your Medicaid. So if we put the two together, you guys have, I think it's 88% of your patients are Medicare and or Medicaid. Medicaid has the same exact structure. So these are both federally funded programs. They have a fee schedule allowable. And if you look at those dollar amounts, they're pretty low. I don't want to be too crude about it, but I mean, money is better than nothing. But they're really low compared to most other plans and what they'll pay, including Medicare. So just looking at that BLS emergency, they allow $311.42. And then Medicaid will only pay $3.75 per mile after 10 miles. So if your transport is 1.7 miles, they will not pay anything for the mileage on that. They do allow payment on non-transports though, so there is a benefit to that. And then Medicaid is what ties into the GEMT program. So that's that supplemental program that kind of bridges the gap between what Medicaid pays and what your actual costs to provide transport. So we look at it, the same exact example for the same type of transport, we have that total charge of $1,771 and some change. Medicaid said allowable is $311.42, and that's exactly what they paid. But Medicaid is considered payment in full. So if you have Medicaid in the mix anywhere, you legally cannot collect anything from a patient. That is another law. So they pay that $311.42, well, $1,460 and change is now a disallowed amount as well. That is why if you guys increase your rates, the more you increase them, the more your disallowed is just going to go up with it. Because if you increase them, Medicare and Medicaid won't budge on what they will allow you to legally collect. The other thing to keep in mind with Medicaid, because they are paid payment in full, they're also payer of last resort. Patients often who have Medicare, or patients with Medicare often also have Medicaid. Medicare and Medicaid have their separate fee schedules. Medicaid will take into account how much Medicare paid, and if Medicare paid more than what Medicaid would have paid, Medicaid will not pay anything at that point, because they will say primary insurance paid more than my contractual allowance. So in this example on the bottom, it's the same charges. Medicare paid that $581.70 like they did in the previous slide. They left that remaining payable amount $116.34. Medicaid will pay $0 on that, and then they will say that the legal to collect anything from the patient at that point. So now your disallowed amount is the $1,190.02. So that is one of the biggest reasons that no matter what, as long as we can meet medical necessity, I can't do anything about getting any more money from Medicare and Medicaid. No other billing company in the entire world can do that. And that's for all medical billing. There is a fee schedule for every service that's payable under Medicare and Medicaid. So then we have your payer mix. This is a report that we do send you guys, I believe on a monthly basis, but we also make it available to request at any point. So what we do is we break down your payer mix to determine what percentage are Medicare, Medicaid, commercial, self-pay, and so on. So this is one that I pulled for dates of service January 1st through May 31st for Western Lane. And it of course shows that high Medicare and Medicaid payer mix. The reason I wanted to show this is when we have clients coming to us saying, hey, we need to make more money, we're going to increase our rates. The first thing we do is we look at that mix, and then we're going to see, okay, well, how much is going to Medicare and Medicaid, is if you have that high payer mix, you're not getting anything more by increasing your rates. If you have a lower payer mix, it might make sense, or another example is if a client came to us and explored the idea of billing for non-transports, I can look at the payer mix and determine what percentage of payers are going to pay for your non-transports. You don't want to start exploring, expanding your billing options if it's just going to hurt your community at the end of it. So there's ways to use this to strategize what you should and should not be billing for. The next piece is medical necessity.
Go ahead, what's on there? So you got firemen or linemen for us, only under private pay, does that mean that it doesn't apply to Medicare, Medicaid patients?
It does as a last resort, so if they have a copay, well, it really wouldn't apply to Medicaid patients because that's payment in full, but your Medicare patients, if they have a copay, your firemen, well, you guys are life med, right? Life med would, yeah, life med would cover it, so if they have a copay for, usually it's about $110, $115, that's where life med would cover that copay.
Okay.
Yeah. So, medical necessity is another big piece of this. All transports have to meet medical necessity in order for insurance to pay for that transport. Medical necessity, there's so many different ways to define it. Every insurance company has a different definition. But generally, we have to have a solid reason why an emergency medically equipped vehicle with emergency medically trained personnel needed to take someone somewhere. You guys have a particularly high percentage of calls coming out of Peace Harbor Hospital. So that means you're taking patients home to skilled nursing facilities, to other hospitals. Medicare wants a really good reason why they should pay for a patient to go home by ambulance. Their mindset is if they're in an ambulance going home and they need that medical supervision just to go home, who's watching them when they get? That's really what their thought process is behind it. So we rely heavily on pre-documentation and other things to meet it, but at the end of the day, you can't, everything won't be medical necessity. You can't stop people from calling 911 for stubbing their toes. You can't stop people from calling 911 because their head hurts and ibuprofen fix it. You can't stop those. You guys do generally pretty good job with meeting medical necessity. In 2025, we've had 1,350 billable calls, and the sample I pulled in 39 of those did not meet medical necessity. All 39 were transports to a lower level of care, meaning I couldn't justify why that person needed an ambulance to take them home. I can look for keywords in it, but at the end of the day, Oregon Medicaid has put things in place to try and, take care of this. It just doesn't mean that the hospitals always, do that side of it. So they have this brokerage plan. They want them to call brokerage before they call an ambulance. Not every hospital is on board with that.
So that means it's 2025.
That's just 2025.
We've done more calls than 39.
So we get paid for spending.
You get paid for some of them. So some of the things that Medicare will pay for is if you guys do any sort of intervention or if I can prove that patient's safety or health within it. So if you have a patient that requires supplemental oxygen, if I can prove you guys had to be the ones to administer it, I can get that patient. If they have a wound vac, that's payable. It's easier to get them paid when they're going to a SNF than it is for them to go to a residence. So you guys do have a high amount going to skilled nursing. So those are likely the ones that are getting paid, so it's something. If the crews had a reposition during transport, I can prove that the taxi driver is not going to reposition someone during transport.
You're gonna tell us a bunch of secrets tomorrow morning, right?
I'll tell you all the secrets tomorrow morning.
That's sort of disappointing. I thought there was a big cash cow we're missing out on, but like, you guys are catching most of them.
My job is to uncover every single rock and figure out the best way to capture every penny that possibly exists. And some of it is strategizing. So there's a fine balance to everything we do. We want to capture every penny possible, but the key is making sure it's compliant. You don't want an auditor to come in, audit you, and you're paying back plus some. You can have an audit where they extrapolate and they could potentially require you to pay back that error rate percentage of all revenue for the entire year, depending on the payer. So it can get really bad really fast. Is it quite similar? Our highest audit we've had so far since I've been there is, it's been right around 2.6%. Most of them come out with a police audit. We won't bill something that you won't be able to keep the money for, which is hence the crews as in like, yeah, I'm the one that sent the reports back. We won't keep the reports if it's not, my own. So then we have this report, it's called our annual collection statistics report. We use this report to have a general idea of how your collections are going. And so in this report, man, I wish I would have blown it up a little bit more. This is for 2024. So you guys had a net collection rate. I can't see what that number is on there. 30, so that's your gross, and then right next to that one. 84?
84%.
Okay, so that means, you guys, had an 84% collection rate on the claims that we billed, meaning, the reason we don't go after the gross is because if you have really high charges and a really high Medicare and Medicaid mix, it doesn't look that nice comparing that Medicare and Medicaid payment against what you charge. There's really no way to make it look nice. So we do the net collection rate, which is a formula that takes into account the disallowed amount, your fire med amount, and so on. And so then, a really important piece to look at this is your uncollected column and your pending column. Your uncollected column, that's the money that we couldn't collect because either the patients refused, we couldn't get a hold of them. You applied financial aid, which that is a very popular thing in this area. And then that pending amount is the amount that we still have open, whether the patient's making payments, we are trying to get insurance to pay for it. We don't call a claim uncollected until we literally exhausted every effort possible.
Yes.
So then I took the same exact report and I actually took out all the pending claims. So I took every single transport that we had in our system where there wasn't a balance pending. These are all settled claims. So I can see on the claims that are completely closed, what is our true collection rate for it? And we were at 90%. So every single one of your claims that thought paid in full, 90% of that money was collected, taking into account that disallowed amount. So
That's probably pretty standard.
So we have some clients that are very, you know, hands off when it comes to a lot of it. They might be very heavy volunteer based, rural. They don't have a lot of the same crews coming in. And we have some clients that have some pretty rough collection rates. And we have some clients that have good ones. I would say anything over like 80 to 85% is considered good. We have some clients that have gotten up to the mid-90s, but they also have someone that reviews every single chart to its fullest before it comes to us. And it's kind of like that picture perfect of every chart possible, which we would never ask anyone to do. Because there's a balance of that admin work and our side of it. We don't want anyone to have to do that in depth of a review on every chart before we get it. So then I did the same report, employing it from June of 2024 to May of 2025. And I only pulled this to give you guys an example of how important it is to take into account the date range. We do typically it's about a 4 to 5 month process for every claim. So if we say a patient has no insurance, we invoice them. And by the time we get to the point where we would consider settling into collections or writing it off disallowed or whatever we have to do, it's been about 4 to 5 months. So you want to pull a historical report to really capture how much you're actually collecting. If I pulled last month's report, it's going to show almost everything is pending still. Most insurance companies take about 3-4 weeks to process a claim. Some of them can take several months. There are some scenarios where they send a payment and they never notified anyone of it. So we have to call them, get a check tracer, try and figure out where it is and go down that fun little rabbit chase. So, this is just why it's important to go on a historical base. I would say at least 4 to 5 months back to get a true idea. Then we go into our level of service summary. So we also have this report available. I do believe that's included in your month-end reports as well. And this breaks down how many transports fell into what level of service. And then it gives us the average of how much we collected on every single one of those. So we can say on average, we collect X amount of dollars for your ALS 2 and so for your specialty cares and so on. This report, because I compared it to 3 different years, that's just a lot of numbers. So I put it into a graph in the next slide. So this shows that over the last, from 2022 to 2024, everything has been pretty as consistent as we could possibly get it. So this is comparing the levels of service and how many transports fell into each one. So if we look at it, we can see that the green is 2024, blue is 2022. You guys have increased your ALS 1 call. Your ALS 2 is increased slightly since then. Your specialty care transport, so those went down since 2022 and 2023. But if we look at the average collected on each one, it stayed pretty consistent over the 3 years.
So our number of specialties gone down,
Yeah,
and that's just because we have fewer or because we're not.
you have fewer.
trying it?
I don't know if it's because there's missing documentation, it's strict criteria, what means specialty care, so we need the critical care, qualified medic, and then we need that advanced intervention, something that the normal paramedic isn't qualified to perform. So I'm not sure, maybe just, it could be multiple things, which is why we're doing training tomorrow.
I can make a point, Alyssa said that we should stop taking offers.
Well, I thought we could charge it.
Get a non-emergent transport for us, and we can send them that way.
They have services available for those calls.
Not in town.
The brokerage,
Where are they at?
well, call Medicaid, call them. They
They
make,
won't do it out here.
they make the rules not.
They won't do it out here.
So there's no right source, I think right source is your brokerage.
Yeah.
They will only take Medicaid patients. They don't get Medicare, so, and most of our patients are Medicare that need to go non-emergent to home or to their facility.
That's when we talk about getting a contract with the hospital, telling them if you wanna call us, we'll take the patient, here's
Work it
the
out.
patient. If there's contracts that exist where you tell, I mean, it has to be like a two-way street on it, you also. I'm not a lawyer, this is not legal advice, if you want to seek legal advice, should we go a contract route? But a contract you get once where it outlines that we will take these calls for you. However, if it doesn't meet medical necessity or if you fail to provide the necessary forms for us to get reimbursement, you are responsible for the balance. And typically you agree to on a lower rate, what usually it's Medicare allowable, that we'll just require you to pay the Medicare allowable, because that's what we would have missed from billing the claim.
So about 10%.
Welcome to medical billing.
Oh, I know.
Yeah.
I know.
There are a lot of challenges with it, which is, yeah, it's a fine balance, because then at the end of the day, your Medicare patients could potentially get a bill for everything their insurance doesn't cover. So if you have a Medicare patient on those transports home and say it's a couple $1,000s, your Medicare patient gets that bill unless you have policies in place to help them with it. So we always try and find a balance of capturing every penny possible, but we also want your community to have a very positive experience with your organization. You need them to vote for your levy, you need them to support you. So it goes beyond the physical care. We get the calls of how much they love the groups in that piece. The last thing we need are patients to call us and tear us apart. We are a continuation of your reflection of the service you provide. So we always try and find a way to make sure your patients aren't going to get hurt in the process when it comes to those bills. They're making sure you can get every piece of compensation you possibly can. All right, so then we also send this quarterly statistics report. This is a report that's a little bit different than everything else we do. Everything we normally do is based off of a date of service. This is how much we billed out for the month of June versus how much we collected for those transports. This one actually goes off of transactions. So it's how many charges did we bill out in the first quarter of the year? The date we billed it, not the date of service, versus how much money did we deposit for you guys for that same quarter? So if we look at this, this is a good way for us to make sure that there's also really no gaps. There are months where you may have a high and then it can dip down a little bit and go back up. There's a little bit variation in it. We try to figure out the rhymes and reasons for it. Some of it doesn't make sense. So like fourth quarter, you would usually anticipate you would have a little bit lower in your collection because everyone's on holidays. We typically don't get reports in a timely manner. Insurance companies have closings. And then January, for example, we got notice that Pacific Sorts was delaying some of their payments. They were having some processing issues. So sometimes we can figure out, direct kind of like that cause and effect of what happened. But as long as we see things that keep staying within a trend, we're typically okay.
Store, so.
So then I put this one into a chart as well, just so we can see how it's kind of gone out. So we have the charges and payments, and then I did add the claim amount for each month because you guys have some interesting highs and lows in your transport counts. I would have always assumed summer would have been absolutely insane for you guys. But there were some months where in the winter, you guys had really high call volume. There wasn't a ton of consistency on, finding highs and lows in that. But generally speaking, we can see that the charges have gone up over the years. You guys have done rate increases. I don't think you've done one of those since 2018, I wanna say, right around there. So, you know, they stay pretty level at that point, but we do see that the charges do generally, or the payments are generally going up each month, just a little bit, at the very least. We never wanna see a drastic dip in those charges, that's, or the payments, that's when we start looking for problems, what's causing that. So really, at the end of the day, Medicare and Medicaid are the biggest reasons why revenue looks the way it does. We will capture every penny we possibly can, and the goal is every penny you put in that bank account, it gets to stay in there should an audit happen. The thing about audits is that they're completely random, we have no clue when they happen until we get the notice the client is under audit. And something to keep in mind though, there is a huge influx of audits right now during the public health emergency. They actually had a waiver out in place saying that they were not allowing any audits to occur. During that time, they were also paying for a lot of transports they normally wouldn't have. They were paying for people to take patients to urgent care and physician's offices and COVID isolation hotels and everything else. So they were paying for a lot more than they normally wouldn't, but they weren't auditing to capture some of that overpayment. The PHE ended and they hit their ground running. They are wanting to get every penny they possibly can back. And so, you know, we're just going to ensure that whatever we get from you guys, we're keeping it. We don't want to pay anything back. And the other piece with an audit is they can also go back another year. If you have a high error rate, they can go back another year, do another audit. So our goal is that you guys potentially get an audit and 0 error rate, maybe 1%, because your crew forgot to sign their name or whatever the auditor wants to hit on, but that's about it. Any question? Yeah,
So 20% is like private insurance, what will have to pay, correct?
or you can think about 12%.
Well, what percentage of that do we get the full reimbursement of what we charge?
It completely depends on the plan and the policy. Something that's actually really good to maybe bring us. So we're in, unless something's come out as of today. You guys have a Balance Bill and Protection Act that is more than likely going into effect. Everything I've tracked up until yesterday, everything's looking positive. Everyone's approving it. It has, I think, another couple days before it's finalized. And so prior to that, right now, commercial insurance can pay whatever they want to pay. They can send us a check for $200 and we have to balance bill the patient for everything outside of that. Commercial insurance does that because they say, well, this is how much we would have paid if you were an in-network contracted provider with us. They then send the patient a letter in the mail that says, well, your copay is only $50 for anything. That's it. So when we send them the bill for $1,500, we get some very interesting phone calls on occasion. So they have this new, I think, House Bill 3243 that is going to go into effect. And what it does is it allows you guys to submit your rates to the state, and that now requires commercial insurers that are participating in it, which most of the big ones are. It requires them to pay up to that full charge amount, except for copays, deductibles, and co-insurance. So I'm very pro for it. I love it because we do now have some control over forcing the commercial insurance companies to pay a little bit more than what they were for. So typically we would have been like, well, commercial insurance pays almost the whole thing. It just depends. Sometimes we'll get them to pay a full claim. Sometimes they pay a couple $100. Hopefully next year when that act goes into full effect, they're going to pay a little bit more.
The reason I asked, seems like why do we come forward and say that rates, if we're getting such a small percentage of that, right? So we're really just getting the small rates.
Yeah.
The other question I have is why is Medicaid 3 times payout for specialty care? Almost 3.
Trust me, everyone in every other state wants to know why they like that in Oregon too. Your specialty care is paid very high in Oregon compared to any other. I don't want to say any other state. Any state in the Northwest, you guys get paid very high for your specialty care transport. They're expensive to do, so that is probably part of it.
Sure.
Um,
So we're gonna start going for fire responses. You got other agencies that do, how's that been working?
It depends on the area, so the way that we structure that is we only bill you guys if we are successful collecting on it. Because it's kind of that hit or miss, some agencies do very well with it, some don't, but that's, I think it's a great thing to explore, especially if you guys do a lot of MPA cleanups, salt alarms, types of things. Yeah, it can be successful for some agencies. I can't say confidently it is a widely successful program, but it's definitely a place to look if you are trying to capture a little bit more revenue, to do that, because what's the harm in it? It's really kind of, you know, you're not going into the negatives of doing it. You're not going to pay us to not get anything out of it. We only charge you if we're successful in getting something for you.
More question. We do a lot of education rounds where we do assessments, 12 leads, we don't bill for that. We don't reimburse, and I heard you remember that insurance may start paying for that.
So, there's multiple ways to answer that. So, is up the different insurance companies. So Medicare, they did the ET3 model, and I think they actually just stopped doing the program a couple years into it because they didn't have enough agencies participating to give them the best data they needed to see the success in doing. I think it's called like tree triage and I probably look, so don't quote me on that, but like it was Medicare looking at, you know, possibly paying for non-transports and exploring that. They don't pay for non-transports, so if you want to bill for non-transports, your Medicaid patients will get a bill for it. Medicaid does pay $420.62 for non-transport, so that was a waiver they put into place during the public health emergency, and they continue that waiver beyond the public health emergency. Commercial insurance typically pays them, so that's where that peer mix comes in. You guys have Medicaid patients, so it's really trying to figure out, are a lot of those calls typically going to your Medicare versus Medicaid? You know, trying to find that balance there.
What about the mobile integrated health program that we have? Are any agencies able to collect any money out of their visits?
I would have to look into it in more detail on how it's structured in Oregon, but there has been a lot of movement in trying to find reimbursement opportunities. So they proposed, I think it was House Bill 2222 this year in Oregon, and that was intended to kind of address some of that. And so even if those bills aren't getting approved and passed, it is the first time we're starting to see more of them come into place. So it's kind of giving that light of hope that they are looking for revenue opportunities for it. Washington just approved as of July 1st that their community health workers can start billing for their services, which would help those community care medicine programs. So as of right now, there isn't a lot of opportunity. There are some creative ways to go about it, but even then the payment opportunity is pretty limited on what you can do. But I'm very hopeful in the next couple of years that we'll see some more progress on that. The goal right now is that we have to get enough agencies to prove that it's going to reduce the Medicare and Medicaid payments that they're shelling out for these transports. It's going to save them money, not having someone go to the hospital and run up a hospital bill. It's cheaper to pay to treat them at home or give them that type of care at home, services they need to stay out of the hospital. So right now we're in this push of trying to get more of those federal oversight organizations to recognize that.
Are we feeding anybody of the data on the? Cause we were collecting data when it first started. Of how much. Pardon?
For Wendy,
For Wendy.
we still have data, I don't know that we're submitting it to anyone.
I had a question, what about air transport? Say one of our flight medics goes with Reach or whoever. Can we submit a bill for their time in the helicopter?
You cannot. So the way it works is that whoever is the moving entity, so for ground ambulance, it's whoever ambulance is rolling, is that has the billing rights to it. And CMS has a lot of rules that state whatever agreements and contracts you can establish behind the scenes cannot contradict what CMS state. So a really common one we see are like ELS providers driving the ambulance and having a hospital staff or someone get into the back of the ambulance and do that more intense care. You can't bill for their services unless you have an agreement. So when your medics went into someone else's vehicle or, you know, helicopter, whatever they were going into, you can't bill it. You can look at getting agreements with those organizations saying, hey, when we provide one of our crew members, we're going to send you a bill every single time. And it's typically something you agree upon. Sometimes they'll stop using your medics at that point, which isn't the worst thing. But sometimes you then get some compensation that way.
You guys work with MASA or is that totally separate? What, have any insight?
The insurance company,
Yeah,
I mean, sure, we do, we work with thousands of there's a lot out there. I believe we do. There's some, I think that's one that's a common in secondary and Medicare.
Yeah.
Yeah,
Secondary. I mean, sort of like life, but it's nationwide.
okay.
Requirement.
Yeah, it depends, if they pay for claim, and so we don't honor any sort of subscription programs unless you specifically give us permission to do it. So if you honor neighboring agencies, fireman programs or something like that, we would honor it in those scenarios. But if it was a subscription plan, if we build it, if they didn't pay for it, we're going to bill the patient for it. And sometimes with programs like that, the patient could submit a claim to them, and they'll reimburse them. We're having questions.
Thank you very much.
There we go.
Thank you.
Thanks. Okay, looking for approval of the consent agenda, consists of meeting minutes from May 22nd, staff reports and correspondence. Is there anything in the consent agenda that a director would like to pull out for discussion? Monthly financials.
So it's life med season. So we have been busy. We processed 1,064 applications. As of this evening. Yesterday, we managed to get 375 of those checks to the bank. We've also are now live as of 5/1 on the new financial system. We've been pretty busy with that. We've cleaned up all of our GL accounts. We've unified them across all 3 agencies. We've cross-referenced those all back, the new GL numbers to the budgets. And we're currently working on aligning all those with the payroll. In the packet, you all have reports for both Western Lane Ambulance and SVFR from the new system. And I'm sorry we didn't get WLFEA's in there. We tried really hard, but we're still in some processes of looking through getting the numbers from the prior system into the new GL numbers. So we're working hard on that. But for Western Lane Ambulance and SVFR, the trial balances have all been entered. Validations have occurred with these 2 entities. It's still occurring with WLFEA. And we're currently working on our first reconciliation in the new system with all the banks. Budgets have been entered for both these entities for 24 and 25. And so if you want to look at your reports, we're learning how to build reports as well. So unfortunately, and I'm sorry, SVFR did not get titled with SVFR on them. But Western Lane Ambulance did. We learned how to do that mid pulling of reports. One of the nice things about the reports, if you look all these reports will now be tied in with the bank accounts. So you will have a beginning fund balance, starting the new fiscal year. It goes off of the start of the fiscal year, and of course, we weren't on the system in, July. And, then you'll see the net change for the month and then the ending fund balance. So, we should match our budgets, that you see in the paper form, on a monthly basis. Other than that, we're trying to tie up the, in addition of getting WLFEA, live and going with all the reports. We're trying to also close out, year end, which is coming up on Monday. So we finalized the signing of the last checks this evening. Other than that, I really don't have much to report. You will see some differences in the percentages, just because we have, some new account numbers. We've split some account numbers out, and we're going from a system that wasn't a true fund accounting system to a system that is a fund accounting system. So there's been some challenges there with how things are entered. Are there any questions for me in regards to the reports?
Yeah, I do. I'm curious, what does ODF pay us $500 for?
That was permanent peak.
Permanent keep the radio?
Yeah.
Oh, gotcha, all right. I thought so, I just,
Quick question that ties us to the previous report we just had from Melissa. The life med in 2024 calculated about $180,000 reimbursement from life med total, which is pretty close to our total net on life med, anyway, so almost a wash.
Well, then you gotta throw in, I think, advertisements and.
I think we, total revenue was a little higher than that part, so I'm thinking
It's very close to breaking even.
close.
Yeah.
That's pretty good. Good to hear. But life med only applies in the case of private insurance or deductible on Medicare.
I would have to look at your specific policies, it's based off of what you guys said, you have some agencies that cover all out-of-pocket expenses for subscribers, and then we have some that are medically necessary emergency transport only, but the only time it is applied is after insurance has been, has processed. or-
Any questions on financials? Thank you. Old business, we wanted to wrap up our civil service rules, our attorney did look at it, he didn't have any comments. So we're looking for a motion to adopt the new civil service rules. Motion by Director
Second.
second by Director Rio. Mary, can you do a roll call vote?
Director Hubble,
Yes.
Yes.
Director Carrillo,
Yes.
Director Russell,
Yes.
Director Webb,
Yes.
Director Sten. Sten. Sorry. Director Sten.
Director Stan?
I
Would you
tried
like-
to raise my hand because I have a couple of comments and a couple of nit corrections on these policies. Do you want to do that as discussion?
We're looking at the civil service rules.
Yes,
You have comments on the civil service rules?
I do on the reports. All on the policies.
Not policies yet.
All right, I have the thing showing that waving the hand is not working, I guess, but when we get to the policies.
Okay,
Director Holmer.
Yes.
thank you. Okay, now policies, we have some new policy that needs submitted. These are the chapter 5, patient care reports, medical supplies, patient refusal, controlled substance. It's healthcare directives of latex sensitivity, so if you get a chance to read those. Or if we hit you, I guess we submitted those last time, so do you have comments? So Director Stent, now's the time for your comments.
Okay, policy number 500. If the patient is deceased on scene, is there a policy about who's responsible for staying with them? Or is it law enforcement, or the medics have to stay there and contact the funeral home, or?
We're not obligated to stay unless we need to secure the scene, but that's not really our authority. Will Colonel respond and stay if the family is willing to, wants their services? But sometimes if we have calls going off and, there's LCSO doesn't have a deputy and they're coming from the valley with an hour and a half wait time and OSP can't cover them or something, and then we'll lock the door, secure the scene and leave.
Okay. On 502, that's the law enforcement ride-along, protective custody. Is there anything making that mandatory that there has to be law enforcement in the unit? Particularly, I mean, I've been in cases where, the guy's handcuffed to the stretcher. And
So if the patient's handcuffed, we have to either bring an officer or have the keys to be able to treat them. If they need to be restrained by an officer, well, usually we make the officer come with us, or at that point, we might call in, maybe chemically restrain the patient. That way we can manage him, but it's whatever's safest for our people. If it's not the case, if it's not medically necessary to go in the ambulance, and law enforcement might be just trying to dump a patient on us, then we'll just make them take that.
Okay. The rest of this I have are typo type things. If you look at 503.3, item F, you've got the word CHIEFR. That needs to be corrected.
George, can you email that correction to us?
Yeah, I have several of them. You want me to just send you an email? I find when I email something to you guys will send something out and I get it and I try to respond to it and I get kicked out saying I'm not part of that group. So I'm not sure who I can actually email anything to.
I'm currently working on that policy, 503, and consolidating that we have several narcotic policies and procedures that need to be consolidated, so, if you could email me, I may have already corrected that one.
You can just stop by the station when you're in town.
Yeah,
Okay. Okay. Yeah, that'll be easier.
thank you.
Any other comments, Director Stan?
No.
Thank you. Okay, moving on to new business, there's a new collective bargaining agreement for review by the board. Any questions on the agreement? Just some highlights, we still have captain and lieutenant positions, we've added firefighter paramedic, where before it was just paramedics. And we included single role and firefighter paramedics in that one, so we've got single role paramedic. Added firefighter EMT, and we got firefighter engineer, we still have firefighters that are qualified to be engineers, but that's under a bonus system now for that. COLAs were agreed upon, the 3-year contract, 4%, 3%, 3%. Over the next 3 years. We've got 8% bonus for those officers who maintain paramedic certification. And then a 3% bonus for engineer certification. And those are the major highlights. Any questions on the contract? I need a WLFEA on the motion to approve the contract.
I move that we approve the contract.
By Director Russell,
Second,
second by Director Polisi. Barry, can you do a roll call for WLFEA?
Yes. Director Russell,
Yes.
Director Webb,
Yes.
Director Stent,
Yes.
Director Holbert,
Yes.
Director Heppel,
Yes.
Director Lacy,
yes.
Director Crowd.
Yes.
Okay, thank you. So new policies for review, chapter 6. Those listed, so if you have any questions, either send them to us or let us know next meeting. Now we have opportunity for directors, any director comments? Hearing none, no director comments, so our next meeting is Thursday, July 24th at 6 p.m. Motion to adjourn.
Motion to adjourn.
Meeting is adjourned. Thanks, everybody.